All right, and we are honored to welcome Dr. Jeff Lee to our talk today. I have the pleasure of introducing him. He's a gastroenterologist at Kaiser Permanente San Francisco Medical Center and research scientist at Kaiser Permanente Northern California's Division of Research. He obtained his medical degree and completed internal medicine residency at UCSD, followed by gastroenterology fellowship at UCSF, and was on faculty in the Division of Gastroenterology at UCSF for 4 years prior to joining Kaiser. He currently serves as the research lead for the Kaiser Permanente Northern California Gastroenterology Fellowship Program and is the associate director for evidence-based GI on American College of Gastroenterology publication. His main clinical and research interest is in colorectal cancer prevention and optimizing post-polypectomy surveillance. And outside of the hospital, Dr. Lee is an active parent, shuttling his kids to their activities in dance, art, and sports, and watching his son's baseball games. All right, and with that, I will turn over screen share to Dr. Lee.
Well, hello, everyone, and thank you so much for the kind introduction, Nathan. And let me just share my screen for a second. It's been 3 years since the COVID pandemic, and it still takes me a while for me to get things working, so apologize for the delay. So can everyone see my screen right now? Yeah.
Yes.
All right. Awesome. So let me put it. All right, now it's in the presenter mode. So wonderful. Well, it's such a joy and delight to be able to meet with you virtually on this webinar. I get the opportunity to be able to share with you all updates and controversy on colorectal cancer screening and surveillance, something near and dear to my heart. And so, as you all know, this is March 30th. We still have another day of March, and March is Colorectal Cancer Awareness Month. And so, I'm sure you're seeing a lot of messages through social media or through, just through advertisements on colorectal cancer screening and just highlighting the importance of it. And I just want to impart on you and just really, encourage you all that, colorectal cancer screening, that message, the importance of this message shouldn't stop in March. We should continue that even till the subsequent months. And so, but it's nice to be able to devote 1 month, both, in our field, but also from a legislative standpoint to be able to highlight the importance of colorectal cancer screening. So next slide. So I want to share some of the disclosures. Most of my research are funded by NCI, PCORI, the Garfield Foundation, Kaiser Foundation Health Plan, and TPMG's Delivery Science Grants. And so some of the studies that I reference here are funded by these grants. So here are the learning objectives that I would like to talk about. I want you to be able to describe, at the end of this talk, I want you to be able to describe when colorectal cancer screening should start. I want to be able to ask any of you all that at the end of this talk that you'd be able to list at least 2 modifiable risk factors for early onset colorectal cancer. I also want you all to be able to list at least 2 guideline recommended screening tests for colorectal cancer. And lastly, I want you all to be able to describe when patients with 1 to 2, 3 to 4 non-advanced adenomas should have their follow-up surveillance examination. So we got a lot of ground to cover, but the first thing is, why should we care about colorectal cancer? And this is something that you all are aware of, but want to be able to highlight the burden of this disease. And so colorectal cancer remains a public health problem. And in fact, 150,000 individuals are actually diagnosed with colorectal cancer annually. And this is statistics from 2022 noting that about 150,000 were actually diagnosed this past year. And colorectal cancer is not only a big problem, but also it impacts mortality. It's the second leading cause of cancer deaths in the United States, affecting over 50,000 individuals. But there are some good news with colorectal cancer in terms of prevention. And in fact, screening is very effective in reducing colorectal cancer incidence and death. From randomized trials, we've been able to show that nearly 15 to 50% of individuals who get screened can avoid colorectal cancer deaths. But not only is screening important, based on randomized control trials, we've shown that it's quite effective, but how does it work in the real world? And so here's a study based out of Kaiser Permanente, Northern California, that showed that organized screening, meaning that everyone gets, when you're screening eligible, that everybody gets, an opportunity to get screened, whether, we do an outreach with mailed fit or with outreach with screening colonoscopies. And this started about 2006 at Kaiser Permanente, Northern California. And we followed these individuals yearly and up until 2015. And what we noted was that at 2006, the screening participation rate was about 40%. And this increased dramatically after the outreach started back in 2006. And in 2008, we were able to get, in 2010, we were able to reach about 80%. And this started to plateau afterwards. And so we've been able to get about 80% to 83% of the population at Kaiser Permanente screen. And this is mainly through a mailed outreach, fit outreach approach. And so regardless of your race, ethnicity, your gender, everyone that's screening eligible gets mailed a fit. And what impact did this have? Well, in fact, from the beginning of 2006 when it started, all the way until 2015, we saw a dramatic reduction in colorectal cancer deaths. And so here on the graph to the right, we saw a 52% reduction in colorectal cancer mortality. So this is one of the reasons why screening is important. It's effective both in randomized trials and it's effective in the real world. Another reason why screening is important for colorectal cancer is that it can eliminate Black and white disparities. And this is a study from the same population showing that when you offer screening from an organized outreach approach, you're able to get participation rates nearly the same between Blacks and whites. And so what's this approach again? Just to remind everyone, it's a mailed fit outreach along with opportunistic screening colonoscopies. And you could see based on this graph from 2006 was, like I mentioned earlier, that the screening rate was about 40%. And that we were able to increase this all the way up to 80% by 2010, all the way until 2015, all the way until 2018. And the figure on the right, what it shows is that not only do you see a high participation between Blacks and whites, but you see that the disparities in terms of deaths from colorectal cancer between Blacks and whites, Blacks having higher risk of dying from colorectal cancer back in 2006 compared to whites. And you could see in 2018, the death rates from colorectal cancer were nearly identical. So this just highlights that when you get the population screened, you're able to not only reduce colorectal cancer mortality, but you're able to eliminate Black and white disparities. So something remarkable and just an important message to be able to get across to your patients and your communities and also your health systems. So when should we start screening? So in 2021, a big shift happened. At the time, for 2 decades in the 1990s and even till the 1980s, colorectal cancer screening recommendations recommended screening starting at the age of 50. But in 2020, actually in 2019, the American Cancer Society started changing or shifting their guidelines and lowering it to 45 years of age. However, not all the guidelines followed suit. It wasn't until 2021 that the US Preventive Services Task Force finally made that change to lower the screening age to 45 years of age. And this and 2 other guideline societies also followed suit, the American College of Gastroenterology, along with the US Multi-Society Task Force, which consists of the AGA and the ASGE. So the biggest change from the latest guideline shift was that all average risk adults age 45 and older should start screening for colorectal cancer. And this was given a B grade. So why is that important? The US Preventative Services Task Force grading is really important because it offers full insurance coverage. So if you have an A grade or a B grade, based on the recommendation from the U.S. Preventative Services Task Force, all insurances have to cover the screening costs. And so whether it's a colonoscopy, whether it's a FIT, whether it's a Cologuard, all insurance plans have to cover that particular screening test. But as you all know, not every American has health insurance. So there's still a lot of room to work with our legislation, with our Congress, with our president, to be able to ensure that all individuals have insurance here in the United States. In fact, the last time I checked, I think nearly 10% of individuals still remain uninsured. So why did we lower the screening age to 45 years from 50? Well, two reasons. First, there is growing trends from epidemiological studies showing that colorectal cancer among young adults 20 to 49 years of age have increased by 50% since 1990. Pretty alarming statistic. And as you can see from the figure below, on the left, you could see the increase starting at 1990. And we still don't know why this trend started to increase after much of a decline in the 1970s to the 1990s. So starting in 1990, we see a 50% increase among young adults, 20 to 49 years of age. Equally concerning is that adults 50 to 54, on the figure to the right, the rates are also increasing. So we're seeing two alarming trends, both 20 to 49 years, adults 20 to 49 years of age are showing an increase in early onset colorectal cancer, but we're also seeing screening eligible adults 50 to 54 are also getting colorectal cancer. In addition to epidemiological data, we're also seeing modeling data that shows that screening is actually beneficial for adults 45 years of age and older. So if you started screening at least 1,000 adults 45 years and older, you'll be able to ensure that 26 additional life years will be gained. You'll avert 3 additional colorectal cancers, and you'll prevent 1 person from dying from colorectal cancer. So we have epidemiological data along with modeling data to support the lowering of our screening age to 45 years of age. So like I mentioned earlier, why are we seeing this alarming trend in early onset colorectal cancer incidence rates? Is it increased disease occurrence or detection, or is it a new environmental risk factor? So here in this study, also from Kaiser Permanente, Northern California, we're able to show that colorectal cancer incidence rates are increasing among young adults, 18 to 49 years of age, at 1.4% per year annually. But we're also seeing in 50 to 54 years of age at 2% annually. In addition, we're also seeing a rising use or utilization rates of colonoscopy, both in young adults 18 to 49 years of age, along with 50 to 54 years of age. Well, the reason for those who are 50 to 54, you would presume, is mainly for screening purposes, because these individuals are screening eligible from the 1990s all the way to the early 2000s. And you can see that colonoscopy utilization rates have increased by 7%. We're also seeing colonoscopy utilization rates are also increasing annually by 6% for young adults. Now, the question is, what type of colonoscopy are they getting? Are they getting screening colonoscopies? And this would be more increased detection, or are they undergoing more diagnostic colonoscopies? So in this study, we're able to tease out the indication of the colonoscopies. And so among young adults, if you see on the bottom, the 18 to 49 years of age, this is the colonoscopy use is largely driven by symptom evaluation. So these young adults are coming to their primary care doctors, presenting with rectal bleeding or unintentional weight loss or abdominal pain or changes in bowel habits. And the primary care physicians are actually recommending and referring them to their gastroenterologist to get a colonoscopy. And we can see that this has been increasing at 9% annually. Now, could this be for screening? Are young adults getting screening colonoscopies for family history of colorectal cancer? We don't actually see an increase in that. So you could see that this is, pretty much a flat line at the bottom. So the colonoscopy use in young adults is largely driven by symptom evaluation. So there's definitely something going on with adults 18 to 49 years of age. So what's really driving the early onset colorectal cancer? And right now, we don't know. In fact, there's several risk factors for early onset colorectal cancer that's been studied over the past 3 years. It's probably the hottest, scientific question in terms of this field. But what we've seen is risk factors that are pretty much similar to risk factors that we mentioned to older adults that are 50 and above. For example, obesity has been linked to early onset colorectal cancer, but it's a similar risk factor for late onset colorectal cancer. Sedentary lifestyle, sugar sweetened beverages, alcohol use, red and processed meats. One unique thing was a recent study from Caitlin Murphy and her group at UT Houston. She was able to show that maternal obesity was a risk factor for early onset colorectal cancer. Another emerging risk factor that's been highlighted was antibiotics, and lastly, tobacco use. So those, tobacco and alcohol use are risk factors that we commonly, educate our patients regarding things that you can modify. But other things like maternal obesity, that's a new risk factor that is getting a little bit more traction. And so hopefully we'll be able to, get more funding from NCI and other funders to be able to explore what really is driving the early onset colorectal cancer among young adults. So here's the case presentation number 1 for Mr. S. So 79-year-old male with hypertension who presents to your clinic for colorectal cancer screening evaluation. He had a prior colonoscopy 10 years ago and it was normal. He's currently asymptomatic. He has no family history of colorectal cancer. His primary care doc did not feel comfortable recommending a colonoscopy based on his age and asked if you could see him to discuss whether he would benefit from further screening. So his current medications, he's only on hydrochlorothiazide. His physical exam, he's normal. Weight is 160 pounds. His BMI is 24. Labs are unremarkable. So the question to you all, to the group, will Mr. S benefit from colorectal cancer screening? Yes or no? And what's the evidence? So curious to hear what people have in the chat box, and I'll take a look at that. So will Mr. S benefit from colorectal cancer screening? Feel free to write anything in the chat. I'm just curious what. So yeah. So I'm getting a lot of no's, potentially. So let's just go back. So we have a 79-year-old, pretty healthy, had a prior colonoscopy 10 years ago that was normal. So he's currently asymptomatic. So we know this is an average risk individual. He's got no family history. He's quite healthy. He only has hypertension. He's only on 1 medication. Surprisingly, his weight is 160 pounds and he's got a good BMI. All right. So I see a wide range of answers. I see yes and no. So that's good. This is good. So let's talk about the evidence for colorectal cancer screening in older adults. So the U.S. Preventive Services Task Force was able to do a systematic review, and what they found was that the evidence was limited. And so this has been pretty much the same recommendation for the past 3 decades, saying that, they gave it a grade C. It's really, the benefit is likely very small. And you really have to, assess the patient and really determine whether, based on the overall condition, the health of the patient, the prior screening history, and the patient preferences. And so it really, it's going to be a patient physician discussion. And so is there any data to support screening in older adults? And so One recent study from the Harvard School of Public Health looked at this particular question. Is screening beneficial in older adults? They enrolled, well, the Nurses Health Study had about 56,000 participants for this particular study. And this was published in 2021 in JAMA Oncology. And what they were able to find was that if you underwent a screening endoscopy, whether it's a colonoscopy or sigmoidoscopy, after age 75, it was associated with a 40% reduction in colorectal cancer-related mortality compared to no screening, regardless of prior screening history, a 42% reduction if you had screening before age 75, and a 37% reduction if your first screening occurred after age 75. So there is a potential benefit, about a 40% reduction in colorectal cancer mortality. And the number needed to screen was about 198 to prevent one cancer, but 1,600 to prevent one death. And I think I just really want to highlight that, is that, when you're in your late 70s or 80s, colorectal cancer mortality is really the main outcome. And so for the number needed to screen is really high. It's actually 1,600. But one important finding that I gleaned from this study that I want to highlight to you all is that they did a subgroup analysis. And what they were able to find was that among individuals that had severe cardiovascular disease or significant comorbidities, they actually did not benefit from additional screening after age 75. So for Mr. S, from our case study, given that his only comorbidity was hypertension, he may benefit, probably a 40% reduction. And so you can highlight the study and be able to share with your patients is that, among older adults, it's usually the healthier ones that will benefit. And so I believe one of the participants was able to highlight that. And so most patients, that are older adults really, they typically have significant comorbidities at this age. So most will not benefit from colorectal cancer screening. So how do I approach this in my practice? So I really look at age comorbidities. I look at my patient's preferences and values, and I looked at their prior screening history. So was it normal? Did they have high-risk adenomas, or did they have low-risk adenomas? And then I want to look into their life expectancy. So one particular website that I find very helpful to look at prognosis is eprognosis.ucsf.edu. And so this is a so very user-friendly, website that I want you to all be able to, that I want to highlight. This will be able to, you just enter some numbers, some history about the patient, and they'll crank out, kind of life expectancy for these patients. And so if you have significant cardiovascular disease or comorbidities, or your life expectancy is less than 5 years, then I really frown upon, additional screening. But if you're really healthy, like Mr. S, then you may be given the green light. So now that we've talked about when to start screening, and maybe, when to stop screening or when to consider screening in older age patients, let's talk about this particular screening test for colorectal cancer. And so you all know that there's multiple different types of screening tests for colorectal cancer. There's stool-based screening tests. There's direct visualization tests like colonoscopy, which many of you all are familiar with. There's imaging tests like CT colonography. And there's now emerging tests that will likely be available in the near future, probably in the next 1 to 2 years, like blood-based screening tests, metabolomics, and even more emerging tests like a breath test. And so I'm not going to be able to highlight all of these screening tests. What I want to be able to show, share with you all, are mainly the tests that are approved by the U.S. Preventative Services Task Force. I'll also touch upon some new data from blood-based tests, which many of your patients will likely be asking you about, given that at least 3 new studies have just come out, or at least preliminary results have come out from these companies. And I'm going to highlight them for you all. So I want to ask the group, which of the following tests is not recommended for colorectal cancer screening by the U.S. Preventative Services Task Force? A, colonoscopy, B, septin-9 blood test, C, multi-target stool DNA, the D, FIT test, and E, CT colonography. So please enter your answer in the chat box if you don't mind. So yeah. So yes. So the correct answer is septin-9 blood tests. So it's very confusing. There's multiple guidelines, but the main guideline that I highlighted earlier is the U.S. Preventative Services Task Force. And why this is important is that insurances will cover coverage the screening test based on their recommendations. So even though the U.S. Multi-Society Task Force, which is pretty much all gastroenterologists, along with the American College of Gastroenterology, even though they recommend all 6 of these potential screening tests, colon capsule or colon, capsule endoscopy is actually not reimbursed for screening purposes. In fact, it's not actually FDA approved for colorectal cancer screening. However, our gastroenterologist societies have felt that this is actually a test that can be used for screening purposes, and I'll highlight some of the data about that. But just back to the question, which of these are not recommended by the U.S. Preventative Services Task Force? You can see that septin-9 is actually not recommended. And I'll show you some of the data to explain why. So the first, I want to talk about stool-based testing. And so we've seen a huge evolution of stool-based testing over the past 2 decades. We started in the 1990s with really strong randomized trials that FOBT, or the guaiac-based stool-based test, was actually quite effective in reducing colorectal cancer mortality. However, there's many limitations with the guaiac-based hemocult test. You need diet restriction, medication restriction, and there's a ton of false positive. And so this was actually modified in the early 2000s to become more specific. As you know, the guaiac base is an enzymatic process, and so it can be affected by diet or even medications. However, a recently developed test called the FIT test, actually not too recent, actually was developed in the early 2000s, was actually very specific to the human hemoglobin. And so it's an antibody that specifically binds to human hemoglobin. And so because of that, you didn't need any diet restriction or even medication restriction. More recently, this was actually modified even more to become the FIT DNA, or the Cologuard test. And so using methylated markers, or at least 6 methylated markers, Exact Sciences was able to produce a pretty impressive test that combines both DNA markers along with a FIT test. And so this was the Cologuard test, which many of you all probably watched the Saturday Night Live of Matthew McConaughey. I hope you all, if somebody has that link, please share that. It's pretty funny. So like I mentioned earlier, FOBT, this is the guaiac base, reduces colorectal cancer mortality by nearly 20 to 30%. However, the guaiac FOBT actually has pretty limited, sensitivity, limited sensitivity for colorectal cancer and advanced adenomas. You could see the guaiac-based FOBT, the sensitivity for colorectal cancer is pretty abysmal. It's 20 to 30%, and even more, performs even more poorly for advanced adenomas at 6 to 14%. And so because of this, even despite showing remarkable, 20 to 30% reduction in colorectal cancer mortality from randomized control trials, there's a lot of room for improvement. And so this is where FIT came along. And FIT was able to, the sensitivity for FIT for colorectal cancer was about 70 to 80% for colorectal cancer. And the sensitivity for advanced adenomas for FIT is about 28%. So a little about 2 to 4 times better than the guaiac-based FOBT, but still has, some limitations. And more recently with the FIT DNA, or the Cologuard, we can see that the sensitivity for colorectal cancer is about 92%. And so about 10 to 20% improvement compared to FIT. Now, when you improve the sensitivity, you may have to sacrifice a little bit of specificity, and that's okay. In fact, the specificity for colorectal cancer for the FIT DNA is about 87%. So you have about a 13% false positivity. And so those patients will essentially go to colonoscopy, and whether they find polyps, it's still a good thing. And so sensitivity for advanced adenomas for the Cologuard is about double, or at least almost double compared to FIT. So it's about 42%. So just to highlight some of the performance characteristics for our stool-based tests. So has there been a head-to-head trial for FIT versus Cologuard? In fact, there is. In 2014, the New England Journal of Medicine published the Deep Sea study, which compared the multi-target stool DNA versus FIT. And what they were able to show head-to-head was that, Cologuard was superior compared to FIT in terms of sensitivity for colorectal cancer and for advanced lesions. Now, some of the pros and cons for both of these tests. So pros for FIT: no sedation, no diet restriction, it's non-invasive, it's incredibly cheap, about $20, it's cost-effective, and you can actually use it for mailed outreach for population-based screening. Now, some of the cons for FIT is that it's a two-step test, it has to be performed annually. Now, in terms of pros for multi-target stool DNA, some of the pros are no sedation, no diet restriction, it's non-invasive, a 3-year testing interval, and it provides a navigator to help follow up on patients that get the test. If it's positive, they can help direct them to their gastroenterologist. Some of the cons for the multi-target DNA: it's a 2-step test, it's incredibly expensive, about $3,000 to $5,000, and it requires a large stool volume. And so it's not a sampling of the stool, it requires a large volume. And so it's almost like a pint-sized volume of stool. Now we're going to shift our focus to endoscopic screening tests. So we've talked about stool-based tests, we're going to talk about some endoscopic screening tests. And so you all are all familiar with both sigmoidoscopy along with colonoscopy. So what's the data that's to show that's about, what's the data about sigmoidoscopy? Here we can see 4 randomized trials that show that sigmoidoscopy reduces colorectal cancer incidence by nearly 20%, and it can also reduce mortality by 30%. But I bet you, in terms of this audience, it's very rare to see sigmoidoscopy being performed for screening purposes. Colonoscopy in the United States is pretty much the predominant screening method. So what's the data to support colonoscopy? We can see here in cohort studies and case control studies that colonoscopy is quite effective in reducing colorectal cancer incidence by nearly 50 to 90%, depending on the study design. We also see that colonoscopy is incredibly effective for preventing colorectal cancer deaths by 60 to 70%. But as you can see on this data, that all of these study designs are all case control studies or cohort studies. So observational data suggesting that colonoscopy is effective. And we all know that colonoscopy saves lives. And so a very, much awaited screening trial was just completed by the Nordic trial. And this was actually published in the New England Journal of Medicine. And I'm sure many of you all are all aware of the study because it spurred a lot of controversy, a lot of headlines. And so this study by Michael Bredhauer and his group, as you could see, some of the headlines that was posted in CNN: new study examines the effectiveness of colonoscopies. Another one highlighted that how effective are colonoscopies at detecting colon cancer. A new study suggests US researchers overestimate a colonoscopy's ability to detect colon cancer. And so let's talk about this study. So this was called the Nordic trial, and this is the first randomized control trial that compared colonoscopy versus usual care. And usual care was in a background of no screening, actually. And so this was a study carried out in Norway, Sweden, and the Netherlands. And these 3 countries actually did not have a population-based screening agenda or initiative. And so they're able to start the study and offer individuals, they randomized two groups, one to usual care and the other group, they invited them for a screening colonoscopy. And what you see on this figure, on this Kaplan-Meier, is that you can see that there was a reduction in colorectal cancer incidence by about 20%. However, there was no reduction in colorectal cancer mortality. So this is in complete, disagreement with all the observational studies, which I was able to highlight that there was like an 80% reduction in colorectal cancer incidence and a nearly 50 to 60% reduction in colorectal cancer mortality. So this is just the data from the intention to treat. Now, they looked at because the biggest controversy was that only 42% of those who were invited for a screening colonoscopy actually said yes to it. And so the participation rate was really low in this trial. And, the authors were saying, well, what we could do is we could do a per protocol analysis. So among individuals that actually completed the colonoscopy, what did the effects show? So among those who had a colonoscopy compared to usual care, we see a 30% reduction in colorectal cancer incidence, and we see a 50% reduction in terms of colorectal cancer mortality. However, one thing to note is that the per protocol analysis has its imbalances. And so it's almost like an observational study design. And so it's, given the fact that there's some nuances to the study, we want to talk about some of the limitations. So you'll have many patients that come to you say, hey, doc, I just saw this colonoscopy randomized trial showing it's not that effective in terms of reducing colorectal cancer mortality. And here are some of the limitations that you may be able to share with your patients or with your colleagues, and even with the authors, because there's still some burning questions that remain. So number one, 42% participation in this trial. Now, what does that compare to? If you look at my prior slides, I was able to highlight that participation rates in these other landmark randomized controlled trials, they were around 60 to 84%. For sigmoidoscopy trials, much higher. So if you had a higher participation rate, I would strongly believe that mortality risk would be lower. It wouldn't be zero. Number two, the colonoscopy quality. So if you look at the study, 30% had an ADR of less than 25%, which is quite remarkable. And if you look at stratified by certain countries had an ADR, a mean ADR of 14%, and some had a mean ADR of 35%. So this is in complete contrast with what we have here in the United States. Another important finding that you'll have to look into the supplemental appendix is that something I mentioned in the earlier aspect of the trial is that this was conducted in Sweden, Norway, and the Netherlands. One thing that happened in the Netherlands was that they had some issues with follow-up. And so they had to remove that patient from the study. So 10% of the patients were actually removed from the study. And whether that would have an impact on the data is still unclear. But I would argue that 10% is actually a large data. And even if among that 10% of that data, if some of the patients that did undergo a screening colonoscopy had reduction in terms of prevention of colorectal cancer incidence and mortality, that would have potentially impacted the data. And another thing to note is that they lacked information on surveillance adherence. And as you know, that once you get a colonoscopy, you find polyps. And among those patients that have polyps, once they get clipped, they have to undergo surveillance. And so it's a whole process to prevent colorectal cancer. It's not just the initial colonoscopy screening, but it's also the subsequent adherence to your surveillance examinations. And so we actually don't know if many of these individuals actually underwent surveillance colonoscopy. On a similar note, in the usual care group, we actually don't have any information if after they got randomized to the usual care group, did they actually eventually get a screening colonoscopy? Something we were unclear of. And so that can actually contaminate the usual care group. And lastly, the follow-up time was about 10 years. And so we need additional benefit to really see mortality. So another 5 years would be nice. And that's something that the trialists are going to publish in about 5 or 6 years from now. So what are some other imaging tests available? We have CT colonographies and we have colon capsules. So the best data is for CT colonography, which is FDA approved for colorectal cancer screening and is US Preventative Services Task Force recommended screening test. And the data for CT colonography is actually quite good. 86% sensitivity for colorectal cancer and 89% sensitivity for adenomas with a specificity of about 94%. And so here I list some of the pros and cons. The main issue with CT colonography and colon capsule, which is not an FDA approved for this particular indication, and is also not recommended by US Preventive Services Task Force, which means that it's not going to get reimbursed by insurance. The main issue with these is that availability. Not every center or medical center has CT colonography. However, if you're at UC Medical Center or if you're at Stanford, they have CT colonography, of course. If you're at certain, healthcare systems, they have colon capsules, some do not. So it's it's an issue of resources and availability. When I counsel patients, I really think about, these CT colonography and colon capsules as a last resort. I really like to focus on the stool-based testing and the colonoscopy-based testing. What role does CT colonography have? It's essentially for patients that are really too sick to undergo a colonoscopy. These are patients that you're thinking, okay, all right, maybe, they really want to get colon cancer screening. And so this is something that you want to offer them. Or if it's a really challenging colonoscopy, prior patients have failed, or not patients, but prior gastroenterologists have failed. This is a reasonable test to recommend. So let's talk about blood-based testing, because this is something that, we're in the Bay Area, we're seeing a lot of companies invest in blood-based testing. For the past 3 decades, we know patients and physicians have been really pushing for, could there be a blood-based testing for colorectal cancer screening? And what I want to share with you is actually really recent data. This is data from kind of the companies and from the abstracts that they've recently published. So they're not actually they're not peer-reviewed yet, but this is some of the latest data on blood-based testing. We know from a study in 2014 from GUT, from SEPT9, and this is from a study of 8,000 average risk individuals, the EpiProColon or SEPT9 test had a really abysmal sensitivity, pretty poor for colorectal cancer at 48%. And as a result, this is why the US Preventive Services Task Force did not recommend this particular test for colorectal cancer screening. Other companies have now really developed they've moved on from SEPT9. They've really focused on certain biomarkers like RNA biomarkers or CT or circulating tumor DNA or liquid biopsies. Another particular biomarker, cell-free DNA or RNA proteins. And so you could see based on these 3 companies, Geneoscopy and Guardant Health actually really most recently announced their findings, and they showed pretty remarkable results in terms of performance characteristics. The sensitivity of colorectal cancer was 80 to 94%, 83% for the Guardant Health, and Geneoscopy showed a 94%. And for specificity, the 90%, for Guardant Health and about 88% for Geneoscopy. And it's still, both of these tests are still not FDA approved, and we'll see what FDA or CMS will do in terms of these tests. But it's exciting news for patients that there likely will be a FDA approved blood-based test with actually pretty decent performance characteristics. And just to recap, for Cologuard, the sensitivity of colorectal cancer is about 92%. So pretty similar in terms of performance characteristics. And these are, the cost will likely be very similar, I would assume. But like I mentioned earlier, these are yet to be FDA approved, so we actually don't know what the costs are. So case number 2, we have a 55-year-old female who undergoes a colonoscopy for a positive fit, no family history of colorectal cancer, and the colonoscopy shows a 4 millimeter tubular adenoma in internal hemorrhoids. So when should the patient have a follow-up surveillance colonoscopy? 1, 3, 5, 7, or 10 years? So feel free to enter that into the chat box. That's right. So we're getting a lot of answers of D and E, and you guys are all correct. So the biggest change in the recent guidelines from 2021 was that low-risk polyps, that means 1 to 2 tubular adenomas, used to be 5 to 10 years. And a lot of people were actually recommending 5 years, in fact, because the data was pretty weak at the time. The new shift is that patients with low-risk polyps, or 1 to 2 small adenomas, they should get their next surveillance in about 7 to 10 years. So why the extension of the surveillance intervals? So we see here, here we see 3 population-based studies. One from the PLCO trial, another one from Kaiser Permanente, Northern California, and another one from the Harvard School of Public Health, the Nurses' Health Study, and the Health Professional Services follow-up. And what we see is that among patients with non-advanced adenomas or low-risk adenomas, their risk of developing colorectal cancer was essentially similar compared to those with no polyps. Pretty low. You can see that the risk is around 0.4% for low-risk polyp patients and around 0.4% among patients with no polyps at all. And the curves are pretty similar. And so low-risk adenomas are indeed low risk is basically what the guideline said. And so who should you give a 10-year interval? So here in my practice, or in, if you want some, guidance, should I pick 7? Should I pick 8? Should I pick 9? Or should I pick 10? You get this range. And a lot of people are actually recommending 7, mainly because if you look at the data, I go back, is that some individuals with low-risk polyps actually underwent a colonoscopy at year 6 or 7 or 8 around that time, or even year 5. And it's unclear whether that had any impact at all in terms of lowering the risk. It could have, or couldn't have. And so because of that uncertainty, because some of the, the patients with the low-risk adenomas had exposure to a surveillance colonoscopy, the guidelines felt like, well, maybe we should not stretch it to 10 years and give a little flexibility. And so the guideline developers, gave that option and extended it from 5 to 10 years to 7 to 10 years. And so who should we recommend 7 or who should we recommend 10? Well, one approach is if you have a patient that has 1 to 2, non-advanced adenomas that are less than 5 millimeters in size, you can actually give that a 10-year recommendation. Or if a patient prefers longer intervals, or if a patient with, a low-risk adenoma had a prior normal colonoscopy. So this patient is incredibly low risk. And so if patients had a 6 to 9 millimeter polyp, maybe you want to go for a 70-year interval. And what's the data to support that? Well, the New Hampshire Cancer Registry data, from Joseph Anderson, they were able to show that patients with bigger polyps have a higher risk of metachronous advanced neoplasia compared to those with polyps that are less than 5 millimeters in size. So how about high-risk polyps? What did the recent data show? Well, clearly we see that individuals with advanced adenomas or high-risk adenomas, their colorectal cancer risk is markedly higher compared to those with no polyps, nearly 4 to 5 times, greater compared to those with no polyps at all. And so the guidelines reaffirmed that those patients should get a 3-year recommendation. Now, among those with 3 to 4 non-advanced adenomas, that's a new change. Historically, over the past 3 decades, those patients have commonly been given a 3-year recommendation. However, in 2021, the guidelines gave them a range from 3 to 5 years. So what's the data to support that? Well, we know that patients were finding more of these individuals with 3 to 4 non-advanced adenomas, mainly because of improving, scope technology and ADR emphasis in our population. But what we're seeing is that these patients with 3 to 4 non-advanced adenomas, their risk for advanced neoplasia or even subsequent colorectal cancer is pretty low and nearly similar compared to those with 1 to 2 non-advanced adenomas. And in fact, the Europeans, nearly all the European guidelines recommend average risk screening. So they're actually recommending that these patients with 3 to 4 non-advanced adenomas return to FIT screening 10 years after their polypectomy. This is markedly different compared to our guidelines. And so given the body of evidence, which is actually pretty low, there's only about 2 to 3 studies that the risk is pretty low in terms of advanced neoplasia and colorectal cancer. The guidelines felt that it was enough evidence to give them, to stretch them out to 5 years, but they still felt that they knew that given the limited data that, clinicians could still recommend a 3-year interval. So my approach for recommending a 5-year interval, who would I consider? So those with, smaller size polyps, patient preferences for a longer interval, or if they had a history of a low risk adenoma or a normal examination 10 to 15 years ago. Now, how about for serrated polyps? Now, we see this all the time now that our scope technology is better and better awareness too. And what we're seeing is that large sessile serrated polyps have a nearly 3-fold increased risk compared to those with no polyps at all. And this supports the guideline recommendations of a 3-year interval. Now, how about for small sessile serrated polyps, those under 10 millimeters in size? And what we see is 2 conflicting results. Here, one study from the Harvard School of Public Health, we see that the risk is pretty much similar if you have a small sessile serrated polyp. The hazard ratio is nearly 1. Now, here in the Kaiser data, we see a nearly 3-fold increased risk if you had a small sessile serrated polyp compared to no polyps at all. And so a little discordant findings, and the guidelines recommended based on this data that, maybe 5 to 10 years. And so you could go anywhere between that. And some of the limitations of the study was that they actually clumped sessile serrated polyps into serrated polyps, and they included hyperplastic polyps, TSAs, and they also included distal serrated polyps. And so we know that clearly distal serrated polyps probably have no elevated risk compared to patients with no polyps at all. In fact, if you have a distal hyperplastic polyp, the common guideline recommendation would be a 10-year interval. So we know that the Harvard cohort included these individuals. So could that inclusion of these patients with low risk polyps or low risk distal serrated polyps, could that have diluted the effect? And so the evidence is still a little murky about sessile serrated polyps. Now, how about for traditional serrated adenomas? These are incredibly rare. They're mainly located in the distal colon, predominantly in females, actually. And what's the risk of colorectal cancer? If you look at this study this was actually recently published by Samir Gupta's group. I think this is a cohort of VA individuals. What they were able to find was that patients with a traditional serrated adenoma had a 1.3% chance of getting colorectal cancer at 5-year follow-up. And this was actually quite similar compared to those with a conventional advanced adenoma. So advanced adenomas, those with tubulovillous findings, high-grade dysplasia, or even size in terms of 10 millimeters or greater. And so the risk was pretty similar. And those with normal findings, the risk was incredibly low at 0.3%, which is not surprising. And so if you adjust for all the potential confounders, what they were able to find is that the traditional serrated adenomas had a 4-fold increased risk of colorectal cancer compared to normal, and a similar risk compared to those with conventional adenomas. And so a 3-year recommendation is appropriate for these patients. Now, how about young adults? We're seeing more young adults getting colonoscopies, and surprisingly and shockingly, we're actually finding patients with polyps, these young adults. So what do we do if we find a non-advanced adenoma or even an advanced adenoma? Well, what we're seeing is that their risk of developing an advanced neoplasia is actually lower compared to those, compared to their older counterparts. And this is consistent with those with non-advanced adenomas and those with advanced adenomas. So this is a cohort of 11,000 individuals with a median follow-up of 7.3 years. And one thing to note is that even despite having a family history of colorectal cancer, they did not have an elevated risk. They, as in young adults, did not have an elevated risk compared to those who are older adults. And so some of the take-home points. 45 is the new 50. So colorectal cancer should start at age 45 for average risk adults. Silver and fit. So you should consider screening in older adults without any cardiovascular disease or significant comorbidities. We talked about all the screening tests, but the best screening test is the one that actually gets done. I typically prefer colonoscopy and fit. 7 to 10 is the new 5. So surveillance colonoscopy in 7 to 10 years after a low-risk polyp removal, and stick with the plan. And what do I mean by that? Is that the current surveillance guidelines are sufficient for average risk young adults if you find a polyp. So I want to thank everyone, and I'm open to questions.
Thank you, Dr. Lee. We have currently one question in the chat from Mikhail. You addressed this a little bit already, but if you were a PCP at Kaiser and a 55-year-old man came to you, which between FIT and colonoscopy, which would you offer?
Yeah, I would actually offer both. I would talk about the pros and cons. The cons of FIT is that you have to take this annually, but it's non-invasive. It's something that you could get it completed at the comforts of your own home. Versus colonoscopy. I think colonoscopy is really a strong, very impressive, has the preventative aspect of it because it can actually identify polyps at an early stage, and you can actually, prevent cancer by removing these polyps. However, it requires you to take some time off from work. It's also a little bit more invasive compared to FIT. This is a very common question, but I think it's really, you have to really meet the needs of your patient. You have to really, understand what their fears are, and what concerns they may have, and think about their preferences based on what they share with you. I could tell you something, and personally, my father refused a colonoscopy. I actually said, hey, his son's a gastroenterologist, and my father, kept on refusing, and just said, hey, I'm going to turn in my fits because I prefer that. And he had 6 negative fits in a row, and his 7th one turned positive, and lo and behold, he had a stage 2 colorectal cancer. And so he had a sigmoidectomy because of that. But, I'm thrilled that he got screened because FIT worked. It actually detected at an early stage. And if I only offered him colonoscopy, he would actually refuse that. And he probably potentially would have never gotten screened. So this is something that, we are in this field of GI, and we perform, we do colonoscopies for a living. It's really important to really, really think about what your patient, prefers, and highlight some of the pros and cons, and really meet them where they are. Some of them have an incredibly challenging time to get time off from work. We're all physicians, and even for myself, it's like thinking about, oh my goodness, how am I going to take a day off from my schedule to get my colonoscopy? It's challenging. So just think about some of these hardworking, men and women that, are struggling just to find time off from work to get their colonoscopy, even finding a loved one to be able to take them to their appointment. So there are options, and we really need to emphasize that there are options, and the best test is the one that actually gets done.
All right. And I know we're running a little bit over time. I have one last question for Dr. Lee. Can you briefly kind of touch upon, have patients come to you with questions about things like chemo prevention, if they're from a slightly higher risk profile? How do you counsel these patients? What's your current approach?
Yeah, my current approach is I like to, from a modifiable risk factor, sedentary lifestyle, obesity, red ultra processed foods, tobacco and alcohol, really limit that or even cut that out. In terms of chemo prevention, aspirin has the best data. There's really, you'll have some other, for high risk individuals like those with polyposis syndromes, like Sulindac, I don't really recommend that for the average risk population, but from an aspirin perspective, there's, the most data is for aspirin. I'll consider that for those individuals with cardiovascular disease. However, I would also caution, individuals that don't have it and they're considering aspirin to think about some of the GI side effects, and that is a GI bleed. Obviously, GI bleeds are not life-threatening, or at least most of them are not life-threatening, but it is still something that, causes a lot of morbidity, and something to think about when considering aspirin as a chemoprevention agent.
All right. And with that, thank you, Dr. Lee, for this insightful talk. And we'll see everyone at the next webinar.